A very good morning to all. First of all, I thank MJK sir and his team for inviting me for this talk. And I think after hearing about liver disease, we are a little bit alert and tense. Who are having fatty liver, I think most of the people are alert. So we go through another scary problem of stroke. So basically, I just go through because it's a very vast topic, like we told, beyond and after golden window, which means involve every management aspect of stroke. So I will just go through few areas, then we can discuss. That will be better rather than talking on all the aspects of stroke. So basically, very crowded slide, but it is taken from WHO. We have a big problem of aging population, and we can see the low middle income countries, including India, is going to have the 90% burden of stroke. That's a very scary thing, that we are going to have the largest number of stroke patients in the world, especially India, China, and other Asian countries. So 1 in 4 people will have a stroke in their lifetime. That's also a scary number. This seems to be very scary for of the whole of the 1 in 4 of the people will have a stroke. So that's a scary number. So we have to concentrate more on stroke prevention, healthy lifestyle, rather than, of course, we have to do acute treatment, thrombolysis, all these things are very important, but at the same time, we have to have very early preventive measures to prevent stroke rather than having thrombolysis or thrombectomy after stroke. So there are clinicians' issues, like when we treat stroke, like unlike MI, when you get an ECG, you get a patient immediately to the cath lab, get everything settled. We see patients come into the emergency, give them a call, they will come take over the patient, everything done, they do angio. But for our stroke, there is a problem. We need first CT scan or MRI scan, then we need a report of that radiologist, or we have to assess the scan, that all, and also we are very time bound treatment. Sir was mentioning about the 1.9 million neurons lost every minute. So every minute is important for stroke. But at the same time, it is difficult to get a correct diagnosis and CT scan report or angiogram report. So we have to wait for the radiologist. So it is time bound. Then multiple team members should be involved. That's the issue. Because for heart, cardiologists will take the patient to cath lab, they will do the angioplasty. For us, because we have to get the radiologist, get the cath lab ready, then get all those things organizing a little bit slow. And also, our system is not very much accustomed to thrombectomy or management. Recently, it is getting better. Previously, it was very difficult. So then management of complications, patient can have more complications for neuro intervention compared to cardiac intervention. That we really understand. The patient will have bleed, worsening GCS, all those things. So, and we have to institute not only acute treatment. The most important thing is prevention in stroke, because once we save the patient from stroke, it is very important for prevention. So this is the same thing which we were talking about. 1.2 billion neurons are lost per stroke. We can see how so this is the diffusion scan of the brain showing initial infarction. After 12 hours, we can, after a day or so, it is evolving in a better shape and become a larger infarction. So that's very important. So over hours, the infarction is growing to a bigger size. Similarly, if the patient is not properly recanalized, we can see there is a right MCA occlusion, right metacerebral artery. This is the right side. There is a small infarction to begin with at 6 hours. This was a good patient for opening with thrombectomy, but it was not done. So what happened over a period of time, by 24 hours, the infarction became fully evolved, became a large infarction. So this is the minute by minute growing area. So we have an MCA occlusion here. So there is an MC occlusion here. So this is the lenticulostriate branches of the metacerebral artery. There is an infarction. So whenever there is a large occlusion, large artery occlusion like a metacerebral artery here, we can have an immediate stroke in the basal ganglia, because the basal ganglia is supplied by mostly the penetrating arteries. They are end arteries, so they will have a stroke. But forward flow will be slightly there. There will be support of collaterals to these areas. So this area will be preserved. Our overall aim is to save this area, because this area is going to get damaged if you don't remove this block from here. So this remnant area, this area may be infarcted already, but there will be a capsular syndrome which will recover very fast. But if you do not save this area, this will become a cortical syndrome, which will be a cortical plus a basal ganglion infarct. So it will be a massive infarct. So most of the time, patient comes to the emergency, patient will be coming with a clot here with M1 metacerebral artery occlusion, and patient will be having small stroke here. And this is the time we have to interfere. Either we have to give thrombolysis, remove the clot, then this area will be saved. If you do not do any recanalization measures or delay it, there will be an infarction spreading all across. So there will be a massive infarct, like the previous scan which I have like a slide which we have shown previously, there will be massive infarction. So this is a basic concept. This is very important because whenever people ask what is the window of thrombolysis, like the window we talk about is usually time window. Why time window? Because on an average by 4.5 hours there will be a lot of damage on an average. It is not 100%. So basically there is a time where with maximum damage can happen is 4.5 hours. That is why we take 4.5 hours. It is not absolute. There is nothing absolute time. Absolute is actually tissue. So there is tissue window and time window. Time window is majority of the patients will have damage by that time. That is a time window. That is used for a guideline because you cannot go to every patient, look at the perfusion and see whether he is having any penumbra or not. So this concept is important. This is the infarct core where one vessel is occluded, the maximum ischemia happened, this tissue is lost because the blood flow reduces to very less to 10. So this is a normal blood flow, cerebral blood flow that reduces to 20 or below, it can get infarcted. So penumbra is an area where there is around between 20 and 60 or 20 and 50. That area is actually we can save. That is the importance of removing the clot. This is the artery, it is blocked. There are collaterals that supply this area, oligemia. Oligemia is normally functional tissue, but there is ischemia. That is why when we take a repeat scan, we are getting a big infarction. Initially a small infarction because the oligemia and the penumbra will completely get converted into infarction. That is a problem if you don't do intervention at the correct time. So this is this is a very important concept because we do all the interventions. That's where time is brain is a principle. Any intervention in stroke management is based on a principle, time is brain. Because it is not only because thrombolysis, thrombectomy, it is also for hemorrhage. Intracerebral hemorrhage, when the rupture of the vessel happened, there is an ongoing hematoma. If you do operation early, it is much better. After 3 hours, there will be a big hematoma. The damage will be more. Patient will be comatose. Otherwise, we can save the patient. Like that, cerebral edema. If you do mannitol or 3% saline after 6 hours of cerebral edema, there is no use. But if you see the edema is coming, use early, there is better. So time is brain for everything we do in stroke. For example, people will ask CT or MRI, which is the best? This is often discussed. There is nothing like that. Both are good. CT is less time taking. So in a available scenario, if there is an MRI, which is some protocols of MRI for stroke will be 5 minutes, 7 minutes. If you are able to do 5-minute MRI protocol for a stroke, do that, no problem. But the issue is, we do not want a 25-minute MRI for a stroke. That is why. For time is brain. We don't want to lose time. So everything regarding anti-edema measures, surgery, and thrombectomy, thrombolysis, and imaging, every aspect of stroke management, one principle is time is brain. So that is a very important concept. So this is shown because we will do routine thrombectomy, we will be doing up to 6 hours. But up to 24 or beyond also we can do thrombectomy, but provided we have to establish there is oligemia and penumbra tissue, not the core, the fully infarcted. If you demonstrate that there is enough penumbra and oligemia tissue after 24 hours of stroke, we can do intervention then also. But we should be doubly sure that this patient has got a small core, not a big core. If there's a big core, there will be a problem. So what is the problem if you do a big core? So we are doing thrombolysis at 10 hours and the patient is having an infarct. What will happen? So this is the basic pathophysiology. We got an occlusion of the vessel. So beyond that, there will be inflammation, ischemia, etc., etc. So there is blood-brain barrier here. So blood-brain barrier, actually the integrity of the BBB is maintained by ATP. So there is a food process of the astrocytes which will bind tightly to the capillary endothelium, and that prevents the leaking of the blood vessels. So once ATP is deficient or ischemia is prolonged, there will be leaky endothelium which can cause bleed. So that whatever you do, even if you do thrombolysis or you do thrombectomy by removing the clot from the vessel, the leaky vessels will ooze and patient will have a large hemorrhage inside the infarct. That is why we keep the time window and not interfering, not thrombolysing every patient, not giving thrombectomy offer to every patient, because we have to look that if the patient is already having an infarcted tissue, there will be leaky blood-brain barrier which can cause bleed. So irrespective of the method, people will think that if you give thrombectomy because there is no thrombolysis, there is no bleeding. Bleeding is not related to the antithrombotic agent you give. It is related to the structural pathology happened due to severe ischemia in the blood vessels, causing severe oozy blood-brain barrier. So that is the point. That's why whatever 6 hours, 8 hours bad infarction, we do not want to do thrombectomy. Thrombolysis we forget, but people will ask, can we give intra-arterial thrombectomy? Intra-arterial thrombolysis. Intra-arterial thrombolysis is also same thing. It will open the vessel, cause hemorrhages. That is a basic principle of stroke management. So what are the evidence-based management? We have only 4 evidence-based management, like only is a stroke thrombolysis. Very good evidence. NINS trial, significant improvement in outcome in a very early trial in 1993 to 96. They have done it and published, so that is become the basic first evidence-based management. Then thrombectomy for large vessel occlusion, that is 2016 recommendation. Trial started from 2013, and thereafter it is a standard recommendation for large vessel occlusion stroke. Then comes the stroke unit care. Stroke, this is a very important forgotten evidence-based management, because stroke unit care is nothing but all stroke patients are managed by the same team of nurses, physicians, technicians and others. So that will definitely will have a proactive approach for stroke. Because when we manage everything in the ward, like we have typhoid, we have dengue, we have everything and another stroke, the care, the preemptive management for the stroke patients will be less. So that is why stroke unit care is giving better results compared to general unit management. That is one thing. Then other is decompressive craniotomy for malignant infarcts. That's a very important, because when there is a large infarction, let's see this patient had a non-recanalized right MCA infarction. You can see the big hypodense area here, and we know that this patient is having a tight brain. This patient has to be decompressed. It's very sure. No need to wait. Immediately call the neurosurgeon, ask him to take the scalp out. We can see the large craniectomy, 14 centimeter craniectomy. You can see the brain bulging all out. So if we do not do like this, so this is the evolution. After doing this thing, after 3 months, see that edema has completely gone and it is sunken now. So this is one thing. But if you do not do, this can be like this. A left MCA infarction with artery, you can see the dense artery here, the thrombus inside the artery. It was not decompressed. What happened? It pressed on the falx here, crossed the thrombus to the anterior cerebral artery, opposite side, there is an infarction opposite. So you can get spreading infarction across if you do not release the pressure. So malignant infarction decompression is a class 1 recommendation. So these are the timelines roughly we AHA put to get all the things done. CT scan, the initial assessment should be within 10 minutes in the emergency, CT scan and stroke team within 15 minutes, CT scan less than 25 minutes. So we have to make it imaging interpretation 45 minutes. We have to give at least thrombolysis, this is maximum within 1 hour if the patient is eligible. This is a timeline given by AHA, but sometimes we will do better than this, sometimes we will be worse than this depending on the patient, all the other factors. So, but generally we will keep it as a guideline to go on. So this is again time is brain for hemorrhage. We can see there is a hemorrhage here. A patient with hypertension came with intracellular hemorrhage. We can see contrast CT showing a small spot, is a sport sign. That means this blood vessel is leaking, and look at this after 24 hours there is a significant enhancement. If you control the blood pressure very well and give anesthesia and all those things, this patient can have a better outcome. But if it is not controlled, there will be hemorrhage. So that is the problem. So similarly, you can see initial scan, not bad, looking very good scan, but there is ICA occlusion. We can see the right ICA, MCA here, and left ICA, MCA is not seen. So there's a massive infarction because it was not recanalized. So this is the importance of time, because by this time we could have opened this. If you do not open by this time, this will be like this. This patient will die or he become moribund. So something which we do not want to miss, being physicians or anybody seeing initial CT scan, this is a very sad story of a boy who was in Palarivattam, was an engineering final year student. He came from Chennai for vacation, had some food in some of the eateries around with his friends, school friends, and suddenly he felt vomiting and giddiness. He was admitted to a neighboring hospital, and his CT scan was taken. CT was apparently said to be normal. But he was having hyponatremia, so he was treated with IV fluids, antiemetics, and next day he was very drowsy. Mother was very suspicious. They are very affording high class people, so they identify he was not properly responding. So next day he was taken MRI. We can see complete pontin infarction. So what we have missed here, this thing you are not supposed to miss is a hyperdense basilar artery. You can see a white spot here. This is actually thrombus in the basilar artery. So this is a simple IV TPA because the patient reached home, hospital within 30 minutes of the vomiting. But unfortunately, we may not be able to. There was some suspicion of neurological event because he was a little bit wobbly, but the CT scan was said to be normal. CT scan will be normal in initial 6 hours of stroke, many of the time. So never completely depend upon CT scan. So this is actually hypertensive basilar artery sign. Unfortunately, this is the MRI after 2 days because it was said to be metabolic encephalopathy because of low sodium, repeated vomiting, etc. Repeated vomiting was due to the basilar medullary infarction. So there's complete infarction. Boy is surviving now. He's just like a Stephen, on a completely locked in state, but he communicates with that machine, that the theory of everything machine, that Stephen Hawking's machine. That he comes to the OPD even. He was in Vellore for a long time for rehabilitation, but not fully recovered. So this is a sad story. Be very careful about CT scan normal in a patient with stroke symptoms. Don't just think everything is okay. CT or MRI better, we talk that CT is the best one because it is less time consuming, it is freely available. But MRI is good for certain situations. When the stroke is delayed, like 6 hours, 8 hours, 24 hours, we want to know whether significant damage has happened or not. So MRI would be better if the patient is coming in a later window, not the initial. Initial window, we know the patient is good, we'll go for early reconalization. So this is the perfusion scan. So if there is a delayed presentation of the patient, it will be better to get perfusion scan, but perfusion will identify, these are the 3-4 parameters which we look for perfusion, cerebral blood volume. The thing is, the basic underlying pathophysiology is that when a blood vessel is blocked, the brain will try to compensate to get more blood. So what it will do, there will be venoconstriction. So the blood will not flow out of the brain. So there will be a little bit elevation of the blood volume. So that's called cerebral blood volume elevation. That can happen here in the initial phase. Then blood flow increase is not possible. This is the initial one to reduce because there is a direct arterial blockade. Then mean transit time is the time taken by the contrast to reach there. When there is an arterial occlusion, MTT will be higher. So we can map all these parameters and can get an idea how much tissue is at risk. So there are threshold values for all these things to determine whether the area is completely infarcted or not. That is a cerebral perfusion. This will be useful for delayed presentation of strokes. Yeah, CT or MRI. So something which we have to see in CT is that you can see this peripheral area as a little bit white more than the dark area here. So the white area actually is a gray matter and the dark area is the white matter because this cortex actually we are seeing a line of white line because there is more protein in the cells. This is gray matter. The gray matter contains more mitochondria, Golgi body's activity, so it is more bright. So the down area, the below area is actually only myelin sheath, so you can get to black. So this gray-white differentiation loss is the early sign of stroke. So that we may not be appreciating. Initially, if you see the CT scan, in our mind there's a white blood or something, we will miss it. We just simply discard it. It is normal, but that may not be normal. So we have to carefully look into it. So and there is a 5 to 7 minutes MRI protocol in many hospitals. It is good because it will identify many of the issues with the patient's brain, subarachnoid hemorrhage, mild infarctions, everything. So MRI is better in fact, but it will take time in most of the hospitals. So what imaging we will do? So we'll start with a non-contrast simple CT which is available, and then we'll add CT angiography to look for large vessel block. If there's a large vessel block, we have to give IV thrombolysis plus thrombectomy to the patient. And if the patient is coming in a wake-up stroke, early morning fountain stroke, we know that all the cardiovascular major events could be in the early morning because of the circadian rhythm, increasing blood pressure in the morning. Those patients who are having hypertension, irregular on medication, etc., can have elevation in the blood pressure and they can have events in the morning. So in the morning there is an issue, wake up stroke. Many other people come with casualty, okay, father was found in the morning hemiplegic, fall out of the bed, etc. we will see. So those patients, we do not know the exact time. He went to bed at 9 p.m. After supper, he went to bed. So we do not know the time. So those situations, we can use something called diffusion flare mismatch in the MRI. If there is a diffusion flare mismatch, we believe the diffusion changes are the early changes which I have shown the previous MRI, the white area, the diffusion, and the flare changes will happen only after 5 hours usually. So we can see that if the diffusion is there, flare is not there, we presume that it is less than 4.5 hours or 5 hours. So we may thrombolyze the patient. That is the importance of this one. And even it is still later, we'll go for perfusion scan. So perfusion scan currently will give an idea whether there is a penumbra to save, is there any point in opening the blood vessel, is there a point in giving the IV thrombolysis. That is very important to remember. So basic assessment, we know ABCD, rapid assessment, and then we go for the NHS scoring to know whether. So NHS scoring important because if NHS score is more than 7 or 8, there is more likely a large vessel occlusion stroke. That is an important point here. So this is a 0 to 42 score. Very bad scores are showing very bad infarctions like a basilar occlusion. So there is something called aspect scoring. Aspect scoring is just to understand the plain CT scan to identify. You can see this. Sometimes if you see the CT scan casually, this will be looking normal, but it is not normal because you can see slight dark area in the CT scan. So this is the different areas of the brain marked M4, M5, M6, M1, M2, M3, metacerebral artery, initial part, second part, third part, etc. Supplying these areas, and we calculate caudate nucleus, lentiform nucleus, internal capsule, and insula. This is just a method to identify whether there is a large infarction or not in the initial scan. We will compare here to here. We can see this is a little bit dark compared to here. Sometimes we will miss it in a busy OPD. Somebody come with a scan, we may miss it. But it is better to have a close look at it. We can see this area, there is a little bit darkness, and this is swollen compared to this. I was talking about the increased cerebral blood volume. When there is an occlusion, there is an M1 occlusion here. So that causes cerebral volume, and it is slightly swollen than this. So this area is fully gone. This is a bad scan actually, not a good scan. So this is aspect scoring for immediate identification. So we know the IV TPA is a first evidence-based treatment. So this is a TCD, continuous TCD monitoring. This is a TCD machine, can be placed in the temporal area. We can see during IV thrombolysis there was opening of the blood vessel. So this we can also record. This is an M1 occlusion on the left side. You go on giving the infusion, there will be a sound, tuck, and then we can see the flow volume. So this is a occluded vessel. It opens in real time. We can record, and we can see this is the M1 occlusion on the left side. IV thrombolysis opening this vessel. So never miss this. Many of the things we will think it is a normal CT, but it is not a normal CT. It's an abnormal CT. We can see changes here, but later we can see the gliotic area here. This is a large infarction developed. Never miss this hypertense MCA sign, because CT scan is simply done in every peripheral hospital, and so sometimes what are the contraindications? There will be a big list of contraindications in the IV TPA booklet or in the book, but don't go through anything like that. There are absolute contraindications of thrombolysis, that is a fully evolved infarct. If you are having a big infarct like this, we are not going to do thrombolysis, because I told you the principle. When the fully infarcted brain, full blood-brain barrier is oozy, you can have bad bleed. So we will not do that. And also, this is subdural, we never do that. This is isodense subdural. This is a little bit tricky. If you have just a glance at the scan, it will be looking normal, but there is a swelling here. This is isodense subdural hematoma, which is almost having the density of the parenchyma. So this we may miss. Be little bit careful. At least you are feeling there is subdural hematoma here, which you are not able to see. This is a clear subdural, which everybody will understand. This is isodense subdural. Be careful about it. So we don't want to thrombolyze here. So these are the few contraindications. Then coagulopathy. Major surgeries, thoracotomy, laparotomy, we will not do. Smaller surgeries we can do, like a knee replacement surgery or a ENT done. All those things we can do. So this is an ideal case of thrombolysis. We can see early presentation, left M2 occlusion, and there is an area of perfusion. You can give IV thrombolysis. Patient will do perfectly well. This is the best patient for IV thrombolysis. Thrombolytic agents, everybody knows. Altiplase is the agent which we used to use previously. This is a serine protease. It is a naturally occurring molecule in the body, which is recombinantly made, so that there is less adverse reaction compared to streptokinase. Then we have new tenecteplase, which is actually bioengineered variant of the TPA. It is more fibrin specific. It can be given as a bolus. That is the advantages of it. There are a lot of trials coming where it is shown that TNK is better than TPA. So this is the ACT trial. It is a Lancet trial by Bijoy Menon, our senior, is published in Lancet, and this has changed the recommendation to making the TNK as a thrombolytic agent. Yeah, so these are the contraindications. So there are certain areas of difficult decision: pregnancy, whether to thrombolyze or not, patient non-neural anticoagulant, systemic bleeding, post-surgical. So post-surgical, the thing is, if there is a compressible site, you go ahead with thrombolysis. So we have this MSUs, very commonly getting MSUs, 3-4 MSUs in India. Northeast, we have a project in ICMR. They are having a mobile stroke unit. They will do thrombolysis in the ambulance only. We were also trying to have one MSU in 2014, but it did not work out because of technical reasons. So this is what we do in telestroke. Telestroke is this is a patient in Assam, in Nagaland. So we are examining the patient from Amrita telemedicine, and we do thrombolysis eligible patient. So this was a patient who came with hemiplegia in Dimapur, Nagaland, where we do the telestroke project. So so actually he has quickly improved, so we did not go for thrombolysis. So this is our telestroke consultation center in Assam, Silchar University. So it is actually nothing much. We will get the patient to the ED, do the vital CC, blood draw, immediate CT or CT angiogram. We see the NHS score. There is a disabling deficit. We go for no contraindication. We go for thrombolysis. We will not wait for the lab results. We will monitor the patient during deterioration, during thrombolysis deterioration, and we will repeat this. This is severe angioedema for a patient with IV TPA. So this is a stroke clock we have again told. So now comes the interventional management. We have this, whenever a patient is there with a large vessel occlusion, we have to push them to the cath lab. So this is basically puncture single artery, because patient is already thrombolized. So when you puncture the artery, there is a high chance of bleed. So we should be a little bit careful by puncturing the patient, because we know that we put a catheter early to prevent bleeding, etc., after thrombolysis. It's a very bleeding condition. So while we puncture the artery in a thrombolizing patient, we should be careful. So it should be a single wall puncture. So you have to puncture a single wall and get it along. So we use different type of catheters for thrombectomy. Like this is the balloon guided catheter to block the forward flow here, and then we'll aspirate from here. So this is the aspiration catheter. So these are different techniques, different stents we used to use for taking the clot out. Several modification, technical modification. They go on doing this in order to catch the clot inside this device. So initially it was a stent only. Now they are using so many devices. Also now we are more frequently using aspiration catheters. There is a steel tip of this catheter will not collapse, so you can apply pressure and aspirate. So these are the different thrombectomy techniques we do, and this is one of the case recently we have done. So this is a very simple procedure. We go ahead. So there is an M1 occlusion you can see here. So just one aspiration, you can open it. It is very, actually this is the aspiration. So you can see the catheter round. This is the catheter. There, just a contact on the thrombus. This is the area of occlusion. You keep the catheter there, just put an aspiration, it will completely open. It's a very simple procedure sometimes, but not always. So sometimes we require angioplasty. There is an M1 occlusion here. You can see the M1 is stenosed and there is a thrombus here, complete stenosis here. So we have done the suction, it opened up once, we can see the stent, the retrieval stent, but it again getting close, so it required an angioplasty. Primary angio. Sometimes we can get bad cases like this. There is a very bad ICS stenosis with occlusion. We have opened it initially, but again getting closed here. So we have to go with a balloon and open it again. So we have to put a big balloon and do an angioplasty here. So these are very pronged, difficult cases. So similarly, there's an IC occlusion. This is a recent case. So this patient went very well. This is very unusual. If there was no thrombectomy, I'm sure that this patient will be dead. She is able to walk normally. This is my fellow. And this was a thrombectomy in one of the ICA. So there are thrombectomy done beyond window of 6 hours. And there are evidence, so several trials are there. The principle is they identify the penumbra by different imaging techniques and they will do thrombectomy. So I think again we keep everything, time is brain. If there is a tissue which is viable and the dead tissue is less, we will go with thrombectomy. That is the principle. I don't want to say so many trials, etc., but this is a basic principle that will not change whatever trial comes. So this is sometimes you do direct thrombectomy. Like in the hospital, a stroke comes, there is an occlusion, and we know the patient has got some other illnesses, we do direct thrombectomy. That is not recommended, but we can do sometimes, because this is a young man who came for AICD implantation after he has got cardiomyopathy with a repeated cardiac arrest. So he had a clot in the heart and immediately developed in the ward only. We opened immediately. We did not go for actually thrombectomy. Directly we have done thrombectomy rather than thrombolysis. So basilar thrombectomy, you can get big clots like this. When this is a basilar artery which is occluded, we can see top of the basilar artery occluded. Just aspirate, you can open the top of the basilar artery and save the life of the patient, because this is a very dangerous infarction, top of the basilar artery. So basically this is the protocol. Either it's a CT, in acute ischemic stroke, non-contrast CT, less than 4.5 hours, we go for IV TPA if eligible, then we'll go for endovascular. Similarly, if there is a more than 4.5 to 24 hours, we go for better imaging and choose for endovascular thrombectomy. So beyond, this is the window. We have described this window times and all. So there are several other, it is not a thrombectomy, thrombolysis. There are a lot of issues left after that: BP control, cerebral edema management, management of dysphagia, rehabilitation planning, finding mechanism of stroke and other things. These are all other areas which we have to really be careful about. So post EVT, the blood pressure is less than 130/80. That's the best blood pressure to keep it. But if there is a thrombolysis, we know that 180/110 is the limit for thrombolysis. We have to control to that level. And post thrombolysis also, post EVT, post endovascular thrombectomy, we will keep a better blood pressure control because there is a chance of bleed. But post IV TPA, we are keeping a little bit liberal blood pressure control, 160 to 180. And so we want to avoid very high fluctuation of the blood pressure. And we have to give, if there is a non-recognized patient, we don't want to reduce the blood pressure, because when the vessel is occluded, it is not recanalized. The only supply to the neighboring area is to the collaterals. If you reduce the blood pressure drastically, the collaterals will fail. So that is why we keep the blood pressure slightly high. So these are the things, pneumatic. So DVT prophylaxis is a major issue. We all know different trials and all. So one thing is, small thing is fever control. If you control the fever in 6 hours, it will be better to have, the outcomes are better. So swallowing assessment is very important. Aspiration pneumonia, we have to prevent all those complications. So low molecular weight heparin is a preferred DVT prophylaxis measure. So we can see, so even in hemorrhage, we can give DVT prophylaxis after 48 to 72 hours. In the cerebral venous thrombosis is a condition where even if there is a hemorrhage, we will give full dose of heparin. Please remember that. So any role of, this is one of the problem. All the stroke patients will have Levipil or something loaded, Eptoin loaded. Don't do that. That is not indicated. Unless there is a seizure, no need to give anti-epileptic medication for any stroke patient. Because this is a headache for the following up clinician. He want to taper it and stop it. Many of the patients while stopping will have withdrawal seizure. So unless necessary, we will not give anti-epileptic medications. So rehabilitation starting should be as early as possible if the patient is stable. There is a trial called AVERT trial, which was a negative trial because they mobilized the patient quite early and patient had a lot of complications. So when the patient is stable, we can do early rehabilitation planning. So I think the stroke ICU care is evolving. So these are the preventive interventions, which this LA appendage closure. We know this LA appendage, which is cause of stroke in many patients. If the patient is not able to get anticoagulated, they will do something like closure of the LA appendage. This is a routine procedure for us, is a carotid artery stenting. So many patients will come with carotid stenosis stenting. This is PFO closure. PFO closure is a recommendation now for young stroke less than 65 years. So this is the star flush closure device. This is routinely done for stroke prevention. So this is just not only acute treatment. This is our clinic in Assam, in the T estate area of Barak Valley. There, this patient has come to our clinic, the teleclinic, like initially with like this. He was having severe spasticity and pain. He was not able to walk. And after 2 weeks of treatment, he's walking like this in his neighborhood. He's walking like this. After 3 months, you can see he's doing his job. So this change we can make. We do not want hi-fi things. Even simple physician treatment of stroke and the morbidity of the stroke survivor, we can make this change. So he is now able to do his work. So I think smaller things will make a bigger difference. So this is the mortality. So we have a reasonable mortality, 1 year mortality of 8.5 in the stroke unit. If you manage the patients in the stroke unit and follow up, there will be definitely better mortality. So in conclusion, stroke management is multidisciplinary and a difficult task. So time bound and all these things will make things difficult, but stroke unit care will make a definite difference, and EVT up to 24 hours in selected patients and within 6 hours for all patients eligible. So thrombolysis up to 4.5 hours and beyond in selected patients. And time window is practiced, but originally it is tissue window. Time window is for general guidelines. And I think We have other complications to be managed, including BP management, DVT detection, and stroke awareness is a key among public and healthcare professionals for better outcome. Thank you.